Usually when we talk about a medical diagnosis, there's this certain expectation of precision, like engineering. If you
Mhm.
break your arm, the X-ray shows a jagged white line, the doctor points to it, and that's it.
Right. Which is deeply comforting, for everyone involved. In medicine, we really like things to be visible and neatly categorized into broken or fixed.
Exactly. It's clean, binary, and entirely static. But the moment you step into the world of obstetrics and childbirth, well, that static X-ray machine just completely shatters.
Oh, absolutely. You are definitely no longer looking at a fixed landscape. You aren't just treating, a solitary patient with a localized issue.
Right? You're managing this highly complex, completely dynamic cascade of physical events that involves two completely intertwined lives.
It is, I always say it's the absolute definition of a biological tightrope walk. The margin for error is just razor thin, and all these physiological variables are constantly shifting in real time.
And today, we are pulling apart the survival mechanics of that exact tightrope walk. Welcome to our deep dive. Whether you are, a medical student prepping for boards, a young professional on the ward, or just a self-taught learner who is fascinated by maternal fetal medicine, this deep dive is custom built for you.
And we're using a really definitive map for this exploration today.
We are. We're pulling our insights directly from a highly regarded clinical text, which is Self-Assessment and Review Obstetrics, the 9th edition, by Dr. Sakshi Arora Hans.
It's a fantastic resource, really dense but incredibly thorough.
So our mission here is to provide you with a comprehensive, high-yield summary of this text. We're going to detail the precise clinical criteria, the physiological mechanics, and the emergency management protocols of obstetrics without skipping the crucial facts.
Right, the goal is to translate all that dense textbook knowledge into a clear, logical format that you'll actually retain.
Exactly. So to understand what happens when this intricate biological process goes wrong, we first have to, well, establish the baseline.
We have to define what right looks like.
Yeah. So in a strict clinical sense, what exactly constitutes normal labor?
Well, the clinical term for normal labor is eutopia. And it's not just a loose definition. It has incredibly strict criteria.
Okay, so what has to happen for it to be eutopia?
First, it must be spontaneous in onset. It has to occur at term. The fetus must be in a vertex presentation, which just means the head is pointing down.
Right.
And finally, the whole process must resolve without undue prolongation and with a natural termination. If a delivery deviates from even one of those specific points, it is no longer eutopia.
Wow, okay. And that natural termination happens along a very specific timeline, right? This is broken down into measurable stages.
Yes, exactly. Let's look at the first stage. This spans from the onset of true labor all the way to full cervical dilation.
Which is massive, 10 centimeters.
10 centimeters, yeah. And the duration of this first stage varies wildly depending on the physical history of the mother's tissues.
Meaning if she's given birth before or not.
Precisely. In a prima gravida, a woman pregnant for the first time, the tissues of the cervix and birth canal have never been stretched to this degree. So the physical resistance is high, meaning this stage lasts about 12 hours.
That's a long time.
It is. But in a multipara, a woman who has given birth before, the resistance of those tissues has been permanently altered. They yield much faster, cutting the time in half to about 6 hours.
Okay, so then we hit the second stage, which bridges that full 10-centimeter dilation to the actual physical expulsion of the fetus.
Right, and again, the clock is completely different based on history. It can take up to 2 hours in a first-time mother, but a mere 30 minutes in a multipara.
What is genuinely fascinating here, to me at least, is how the pain pathways themselves physically shift as these stages progress. It's almost like experiencing two completely different types of injury in sequence.
It really is. In early labor, the pain is strictly visceral. It's originating from the intense, rhythmic, muscular contractions of the uterus itself.
And that specific pain signal is carried up the spinal cord by the T10 to L1 nerve roots, right?
Exactly, T10 to L1. But as labor progresses into the later stages, the source of the pain changes entirely. It's no longer just the muscle cramping.
It's the intense mechanical stretching and tearing of the cervix and perineum.
Yeah, and because the source of the trauma has moved, the neurological highway actually changes. That localized mechanical stretching pain travels down an entirely different pathway, the sacral plexus.
Specifically, the S2 to S4 nerve roots. So the brain is receiving a totally different type of distress signal.
Exactly right.
Speaking of the mechanical side of things, the text outlines the 8 cardinal movements of normal labor: engagement, descent, flexion, internal rotation, crowning, extension, restitution, and external rotation.
It's quite a list to memorize.
Yeah, I always picture this process like trying to navigate a large, awkward piece of furniture through a very specific, rigid, curved hallway.
That analogy perfectly captures the anatomical reality, honestly.
Right, because you have a vehicle, the fetal skull, and it has to pass through the maternal pelvis. But that pelvic tunnel isn't a perfect uniform cylinder.
No, not at all. The entrance is shaped differently than the exit.
So the widest part of the vehicle has to continuously pivot to match the widest part of the tunnel at any given depth.
It is an intricate, millimeter-perfect biomechanical dance. The entrance to the pelvis, measured by the obstetric conjugate, is wider from side to side.
Okay.
But further down, the pelvic outlet, which is constrained by the interspinous diameter, is wider from front to back.
So it's totally flipped.
Completely flipped. And because the fetal head is an oval, it has to enter the pelvis sideways, then physically rotate 90 degrees internally just to be able to continue descending.
Wow.
Every single one of those 8 movements you mentioned is a calculated physical adjustment to the bony architecture of the mother's pelvis.
But what happens when that millimeter-perfect dance loses its rhythm? Like, how do clinicians actually track this complex internal geometry in real time without just, guessing based on how things feel during an exam?
Well, they absolutely do not guess. They rely on the definitive monitoring dashboard of the labor ward, which is the partogram.
The partogram?
Yeah, it's the absolute best graphical method to assess labor progress. By plotting everything on a single visual graph, clinicians take all the subjective guesswork completely out of the room.
Right, because on this dashboard, you're tracking cervical dilation in centimeters, the descent of the fetal head, the frequency of uterine contractions, and the fetal heart rate all in one place.
And the most critical visual cues on a partogram are 2 distinct lines, the alert line and the action line.
So the alert line is your early warning system, right?
Yes. If the mother's progress crosses it, the process is mathematically slowing down and you need to investigate.
And the action line.
If the progress crosses the action line, you have officially entered dangerous territory. The biological mechanics are failing and active medical intervention is absolutely required.
But wait, before a doctor even starts drawing on the partogram, they have to ensure the engine has actually started. They have to differentiate between true and false labor because, false labor pains can be incredibly convincing.
Oh, they can be terrifyingly convincing for the patient, but they lack the structural consequences of true labor. False labor pains are irregular, they're mostly confined to the lower abdomen, and crucially, they do not cause the cervix to dilate.
True labor, on the other hand, features definitive cervical changes, regular contractions that build in intensity, and the formation of the bag of waters.
And here's a vital clinical differentiator. True labor is not relieved by sedation or an enema.
Wait, really? Why is that?
Because you can't just relax the muscles to stop it. True labor is a systemic, hormonal, and structural cascade. It's not just a localized muscle spasm.
That makes sense. So if it is true labor and the partogram shows progress crossing that action line you mentioned, we enter the territory of dystocia, which simply means abnormal labor.
Right. And we generally categorize uterine dysfunction where the squeezing mechanism itself is failing into 2 distinct types, hypotonic and hypertonic.
Let's break the physics of those down.
Sure. Hypotonic dysfunction usually happens in the early active phase of labor. The contractions are just, inadequate. The uterine muscle isn't generating enough physical pressure to force the cervix open.
And hypertonic dysfunction.
That's much rarer and usually happens in the late active phase. It is characterized by a high basal tone in the uterus.
Meaning the uterine muscle never fully relaxes between contractions. It just stays clamped down, which, that's terrifying because that constant pressure cuts off the oxygen supply to the fetus.
Exactly. But what if the uterus is contracting perfectly, but the physical passageway itself is blocked?
Oh, right.
That is obstructed labor. And the text lays out absolute golden rules here. You never adopt a wait-and-watch policy, and you never, ever use oxytocin.
Because if you pump oxytocin into a patient whose uterus is already furiously contracting against a solid mechanical obstruction, the pressure has literally nowhere to go.
Nowhere.
The uterine muscle will literally tear open. Uterine rupture is a catastrophic, life-threatening event.
It is. And there is a horrifying visual warning sign of this impending rupture called Bandel's ring.
Bandel's ring, what does that look like?
It's a pathological retraction ring. It's an actual physical groove you can see forming horizontally across the mother's abdomen as the upper segment of the uterus violently thickens and the lower segment dangerously thins out.
Now, wait a minute. I need to ask you about some of this terminology, because when you say someone is experiencing lack of progress or prolonged labor, that sounds, I don't know, entirely subjective.
It does sound that way.
Like if I'm the doctor on shift and it's been a really long night, couldn't I just get impatient, declare it prolonged, and rush to a C-section?
That is a very common misconception, but the text is adamant that dystocia is a mathematical diagnosis, not a subjective feeling. You cannot formally diagnose dystocia based on impatience.
So there are strict rules.
Very strict. According to ACOG guidelines, you cannot even diagnose active labor arrest until the cervix is at least 2 centimeters dilated. If the patient is at 1 centimeter and progressing slowly, she is still in the latent phase. You just have to wait.
So the active phase has an actual speed limit, or, well, a minimum speed requirement.
Exactly, a minimum speed requirement. Once the patient is in the active phase, progress is defined by strict metrics. For a prima gravida, active labor must progress at a minimum rate of about 1.2 centimeters of dilation per hour.
Wow, okay.
If the measurements on the partogram fall below that specific velocity, it is a definitive clinical diagnosis of protracted labor. The math protects the patient from subjective impatience.
That makes perfect sense. So we've discussed what happens when the uterine forces fail or the passage is blocked. But what happens when the fetus itself, is the structural problem?
We call those malpresentations, and the most common by far is the breech presentation, where the buttocks or feet enter the pelvis first instead of the head.
And we categorize those based on exactly how the baby is folded, right?
Right. There's the frank breech, where the hips are flexed but the baby's knees are extended straight up by its ears, almost acting like splints.
Ouch.
Yeah. Then there's the complete breech, where both hips and knees are flexed like the baby is sitting cross-legged, and the footling breech, where one or both feet are pointing straight down into the birth canal.
Delivering a breech baby vaginally just seems like it would require an intense understanding of biomechanics. Like you can't just pull. The text outlines a rapid-fire list of highly specific, almost choreographed clinical maneuvers,
They're
right?
very choreographed.
Like Burns-Marshall, Morisot-Smellyvite, Lovesets, and Pinards.
They are highly choreographed because you are manipulating rigid bones through a very tight space. You have to understand the physics of every single one. For example, delivering the aftercoming head is the most dangerous part of a breech birth.
Because the baby's body is out, but the skull is still inside.
Exactly. And the umbilical cord can easily get crushed between the baby's skull and the mother's pelvis, instantly cutting off oxygen.
Right. And to fix that, the text highlights the Burns-Marshall method, which uses gravity by swinging the baby up and over the mother's abdomen. But there's also the Morisot-Smellyvite maneuver. How does the physics of that one work?
Oh, the Morisot-Smellyvite maneuver is brilliant biomechanics. The clinician actually places their index and middle fingers directly on the baby's maxilla, the cheekbones, while the baby is still inside.
Whoa.
Yeah. They use those fingers to force the baby's chin to tuck tightly against its own chest. This maintains sharp flexion of the head, ensuring that the absolute narrowest diameter of the fetal skull is presenting to the pelvis, while the other hand applies downward traction on the shoulders.
Okay, but what if the baby's arms are extended straight up over its head instead of tucked in?
Then you use Lovesets maneuver. You literally grasp the baby's trunk and rotate it 180 degrees. Because the birth canal has a natural downward curve, physically twisting the baby forces those extended trapped arms to sweep downward across the baby's face and out of the pelvis.
That's wild. And if you have a frank breech with the legs stuck straight up?
You use Pinard's maneuver. You apply pressure behind the baby's knee to force it to bend, which allows you to grab the foot.
It's basically applied physics inside the human body. And I assume this applies to shoulder dystocia too, right?
All right.
This is when the head delivers normally, but the anterior shoulder gets stuck like a wedge hard behind the mother's pubic bone.
Yes, and shoulder dystocia is a terrifying obstetric emergency. The first-line management is the McRoberts maneuver.
How does that one work?
You take the mother's thighs and sharply flex them all the way back onto her abdomen. This flattens the curve of her sacrum and physically rotates the pubic bone upward, which dramatically opens the angle of the pelvis to free that wedged shoulder.
And if that fails?
If that fails, you move to Wood's corkscrew maneuver, where the clinician reaches in and physically rotates the posterior shoulder 180 degrees to screw the impacted shoulder free.
And then there's the transverse lie, where the baby is lying completely sideways across the uterus like a hammock. The text says you manage this with external cephalic version, or ECV, after 37 weeks. The doctor literally pushes on the outside of the mother's abdomen to manually rotate the baby.
Yes, but if the patient goes into active labor with a sideways baby, an emergency cesarean section is mandatory because a sideways baby physically cannot fit through the pelvis. The geometry simply makes vaginal delivery impossible.
Which brings me to a maneuver that sounds absolutely extreme, the Zavanelli maneuver. The text mentions this is used in catastrophic shoulder dystocia when all those other maneuvers, McRoberts, the corkscrew, have completely failed.
Yes, it's the maneuver of last resort.
The physician literally pushes the fetal head back up into the vagina to perform an emergency C-section. It's like, I don't know, putting the landing gear back up and aborting the landing at the very last second.
That's a great way to put it.
But what is the clinical threshold for this? How long does a doctor try pulling before they make the call to push the baby back in and sprint to the OR?
That decision is entirely dictated by the clock and the fetal heart monitor. The moment that shoulder gets stuck, the umbilical cord is compressed. You have a matter of mere minutes before the fetus suffers irreversible, permanent hypoxic brain injury from lack of oxygen.
So there's almost zero time to debate.
None. If the standard maneuvers fail and the fetal heart rate crashes on the monitor, the physician abandons vaginal delivery immediately. The Zavanelli maneuver is the ultimate last resort to save a suffocating brain.
The stakes are just incredibly high. And while these mechanical obstructions are a highly physical challenge, the most immediate life-threatening crises in the delivery room aren't actually mechanical, they're vascular.
Right. Hemorrhage. Uncontrolled bleeding is the leading cause of maternal mortality worldwide. We divide it into antepartum hemorrhage bleeding before delivery and postpartum hemorrhage bleeding after.
Let's break down antepartum hemorrhage, or APH. The two major culprits here are placenta previa and abruptio placenta. And while they both involve bleeding, they present as clinical opposites, right?
They really do. Placenta previa occurs when the placenta implants abnormally low in the uterus, partially or completely covering the cervix.
Okay.
Because the placenta is highly vascular and sitting right over the opening, any slight shift can cause bleeding. The classic presentation is painless, causeless, bright red, recurrent bleeding.
And the management of previa depends heavily on the clock. If the mother is less than 37 weeks pregnant and her blood pressure is stable, the text dictates expectant management, specifically the McAfee and Johnson regime.
Correct. You're basically managing the bleeding to buy precious time for the fetal lungs to mature.
But if she's over 37 weeks or her blood pressure is crashing from massive blood loss, you abandon waiting and deliver immediately.
Exactly. Now compare that painless bleeding to abruptio placenta. This is when a normally implanted placenta prematurely and violently peels away from the uterine wall before the baby is born.
And this one hurts, right?
Oh, it is a highly painful event. The bleeding is dark red. The uterus becomes incredibly tense, hard, and tender to the touch, and there is almost always immediate fetal distress on the monitor.
Because the baby's oxygen supply line is literally detaching from the wall.
Right.
But sometimes, in a condition called vasa previa, the bleeding isn't coming from the mother at all.
Right.
In vasa previa, the fragile fetal blood vessels are exposed and cross right over the cervix. If the water breaks and those vessels tear, the baby can bleed to death in minutes. So to figure out whose blood is leaking out, clinicians use two specific tests,
which rely on the fascinating structural differences between adult and fetal blood. The ACT test is qualitative. The clinician mixes the blood with a strong base, sodium hydroxide.
Okay, what does that do?
Well, adult maternal hemoglobin is delicate and is immediately destroyed by the alkali, turning brown. But fetal hemoglobin, HbF, is structurally tougher. It's built to aggressively pull oxygen in the low oxygen environment of the womb.
Oh, wow.
Because it's tougher, it resists the alkali and stays pink. If it stays pink, you know the baby is bleeding.
That's incredibly clever. And if they need a quantitative measurement to see exactly how much fetal blood has tragically mixed into the maternal circulation, they use the Kleihauer-Betke test, which utilizes a citric acid buffer to actually count the fetal cells under a microscope.
Exactly. So that covers bleeding before birth. But postpartum hemorrhage, or PPH, is equally deadly. The #1 cause of PPH is uterine atony. The uterus simply forgets how to cramp up after the placenta detaches.
And this brings us to one of the most elegant evolutionary designs in human anatomy, the living ligatures of the myometrium.
Yes.
The muscle fibers in the middle layer of the uterus aren't just arranged in straight lines. They form a brilliant, crisscrossing figure-8 pattern entirely wrapping around the blood vessels.
It is an incredible anatomical failsafe. When the uterine muscle contracts, those figure-8 fibers actively strangle their own blood vessels. It's like pulling the drawstrings tight on a bag. They clamp the bleeding shut.
But in uterine atony,
In uterine atony, those living ligatures stay totally relaxed. The floodgates remain wide open.
which requires immediate medical management. Clinicians use drugs like misoprostol, which is a prostaglandin E1 analog, or PGF2 alpha. These aren't just pain relievers, right? These chemicals forcefully command that muscle to cramp up and crush those vessels shut.
That's exactly what they do. Beyond bleeding, the other massive obstetrical emergency is hypertensive disorders, specifically severe preeclampsia. The physical criteria here are strict. A blood pressure reading of greater than a 160 over 110, significant protein leaking into the urine, and neurological warning signs like blurred vision.
And the immediate danger of preeclampsia is that it will progress to eclampsia, which means the onset of generalized, life-threatening seizures.
Right. To prevent the brain from seizing, the gold standard treatment is intravenous magnesium sulfate.
But it is crucial for our listeners to understand that magnesium sulfate is just a temporizing measure. It raises the seizure threshold, but it doesn't cure the disease. The definitive only cure for preeclampsia is the delivery of the placenta.
Correct. For severe preeclampsia, the text says you deliver at 34 weeks. For mild, you try to wait until 37 to 39 weeks.
But regarding blood pressure management, the text highlights a massive, critical contraindication, a trap for an unwary clinician. You must never use ACE inhibitors for a hypertensive pregnant patient.
Never.
In a normal adult, ACE inhibitors are standard, everyday blood pressure drugs. But in pregnancy, they cross the placenta and destroy the developing fetal kidneys, causing lethal neonatal renal failure.
It perfectly illustrates that biological tightrope we talked about. You are treating the mother's blood pressure, but the exact same molecule causes fatal malformations in the intertwined second patient.
To complete this comprehensive clinical picture, we need to step back from the acute delivery room emergencies and look at the environments that support the fetus during the pregnancy itself.
Right, the early complications in the amniotic fluid. Ectopic pregnancy is a prime early complication, where the fertilized egg implants outside the uterus, usually in the narrow fallopian tube. The diagnostic tool of choice here is a transvaginal ultrasound, or TVS.
And there are specific chemical markers in the blood, too. A serum progesterone level greater than 25 nanograms per milliliter is an excellent sign, right? It essentially rules out an ectopic pregnancy.
It does, but if it is ectopic and the tube hasn't ruptured yet, surgery isn't the only option. We can use medical management with a drug called methotrexate, which stops rapidly dividing cells.
But the text is very strict on when you can use that.
Very strict. The patient must be completely hemodynamically stable, meaning her blood pressure isn't dropping from internal bleeding. Also, the pregnancy hormone levels, the beta-HCG, should be less than 1,000 milli-international units per milliliter.
And the absolute best success rates are seen when the beta-HCG is under 200, right? Indicating a very small pregnancy mass.
Exactly. Further along in pregnancy, the amniotic fluid itself acts as a diagnostic window. It's the baby's shock absorber, but it's also a cyclical system. In later pregnancy, amniotic fluid is largely made of fetal urine, and the baby continuously swallows it.
So disorders here point to specific structural anomalies.
Right. Oligohydramnios means there is far too little fluid. Since the fluid is urine, low fluid often points to renal agenesis. The baby's kidneys never developed, so they aren't peeing. Or it could be a post-term pregnancy where the aging placenta is simply failing to sustain the system.
Conversely, polyhydramnios is an excess of fluid. The baby is peeing, but they aren't swallowing the fluid to recycle it. This points to blockages like esophageal atresia, where the swallowing tube is malformed, or anencephaly.
And if the sheer volume of this excess fluid pushes up against the mother's diaphragm and causes maternal respiratory distress, therapeutic amniocentesis is required to physically drain the fluid and decompress the uterus so she can breathe.
And supporting this entire system is the mother's blood supply. The World Health Organization defines anemia in pregnancy as a hemoglobin level, dropping below 11.0 grams per cent.
But waiting for hemoglobin to drop is late in the game. The absolute most sensitive early test for detecting iron depletion is checking the serum ferritin levels.
Because ferritin measures the stored iron in the body. It tells you the reserves are emptying out long before the actual red blood cell count crashes.
Exactly. So we have covered the biomechanics of normal labor, the mathematical thresholds of dystocia, the extreme physical maneuvers for malpresentations, and the medical management of vascular emergencies.
Which means it is time to put you, the listener, directly into the physician's shoes. Let's work through a quick clinical case study based on the precise mechanics we just unpacked.
Let's do it.
Imagine you're the attending physician on the ward. A patient who is 35 weeks pregnant rushes through the doors. She's experiencing sudden, severe abdominal pain. When you examine her, her uterus is incredibly tense, hard as a board, and very tender to the touch.
Okay.
She has dark red vaginal bleeding. The nurse calls out her blood pressure, and it is spiking at 165/115. Based on the physiology we've discussed, what is the primary diagnosis and what underlying vascular condition provoked it?
Well, if we break down those symptoms, the sudden pain, the rigid board-like uterus, and the dark red bleeding, immediately rule out placenta previa.
Right.
The placenta isn't just sitting over the cervix, it has violently peeled away from the wall. The primary diagnosis is abruptio placenta. And when you look at that massive blood pressure spike of 165/115, the underlying condition driving that vascular catastrophe is severe preeclampsia.
The high pressure essentially blew the placenta off the uterine wall. It's the textbook presentation, and understanding the why behind those symptoms dictates exactly how fast you move to the operating room.
It does. And as we wrap up this deep dive into Dr. Aurora Hans's text, I want to leave you with a thought to ponder that pushes beyond the textbook and into the future of this field. We talked extensively about the partogram, the dashboard that mathematically tracks dystocia, but human clinicians can only see a trend once it crosses that alert line.
Right, we are just reacting to the physical data.
But currently, machine learning algorithms are being trained on hundreds of thousands of historical partograms. In the very near future, AI might be able to predict that a mother will experience dystocia or an obstructed labor hours before her cervical dilation ever slows down, simply by analyzing micropatterns in early uterine contraction strength that a human eye cannot perceive.
That is incredible. We're looking at the intersection of ancient evolutionary biology, those living ligatures and pelvic mechanics, and predictive digital algorithms.
Obstetrics is the mastery of a biological tightrope walk involving two intertwined lives. It forces us to ask, as medicine becomes more advanced, how much further can we widen that razor-thin margin for error? How many more lives will be saved when we can see the tightrope fraying before the patient even takes a step?
A truly profound thought to end on. Thank you for joining us on this deep dive. Keep learning, keep questioning the mechanics of the world around you, and we'll catch you on the next one.